talking today about primary aldosteronism and whether it's a zebra or a horse. This talk was inspired by just all of the different phenotypes that we've seen in hypertension clinic as we've checked renin and aldosterone levels. And I wanted to understand a little better this test and how we can interpret it. So I don't have anything to disclose, but I was never one of the girls that liked ponies or horses, but I do like zebras. The outline of my talk, I'm just going to start by going over some basics about aldosterone biology with aldosterone synthesis, RAS regulation, and how aldosterone impacts blood pressure. And that's going to be a good background for highlighting the plasma variability of aldosterone and the measurement of aldosterone in the plasma. I hope to tackle defining autonomous aldosterone secretion. And the bulk of my talk is going to be focusing on new studies that have better elucidated the biochemical profile of autonomous aldosterone secretion. So I thought it was a good time to kind of update us all on some of these studies. So background about aldosterone biology and hyperaldosteronism. So aldosterone is the main mineralocorticoid steroid that is produced in the zona glomerulosa of the adrenal gland. And so right here. And it is synthesized from cholesterol. And all of these steroidogenic reactions are catalyzed by enzymes of the cytochrome P450 family. And you can see that aldosterone comes from the same progenitor as cortisol. Now, aldosterone synthase is an enzyme that sequentially hydroxylates and methylates deoxycorticosterone, which right here. And it's primarily expressed in the zona glomerulosa. It's encoded by the gene CYP11B2, and the expression of CYP11B2 is regulated by RAS. So I wanted to go over RAS regulators, and because that is how that regulates aldosterone synthesis. So we are all very familiar with the renin-angiotensin-aldosterone system, where angiotensin made in the liver is converted to angiotensinogen made in the liver is converted to angiotensin 1 by renin, which is made by juxtaglomerular cells. Angiotensin 1 is converted to angiotensin 2 by ACE, and angiotensin 2 upregulates CYP11B12, and that then causes aldosterone production. Now, there are three mechanisms of stimuli that regulate renin release from the juxtaglomerular cells, and I want to go over these. So mechanism one is when the macula densa senses a decreased chloride delivery to the tubule. And mechanism two is a pressure-sensitive mechanism that senses decreased arterial pressure. Mechanism three is a mechanism of the sympathetic nervous system where that involves beta-adrenergic activation. And additionally, there are local factors like in the juxtaglomerular apparatus like prostaglandin, nitrous oxide, and endothelins that can all cause the release of renin from the juxtaglomerular cells. And we can't forget that ACTH, which is produced in the anterior pituitary, also activates upregulation of CYP11B2 in the zona glomerulosa through this activation of the MC5 receptor in the zona glomerulosa. So this is how RAS leads to aldosterone secretion, how changes in the body will lead to an elevated aldosterone. Now, I want to talk about how aldosterone impacts blood pressure. And really this slide could be an entire talk about the adverse effects of aldosterone on the body. But, to go over it here, we know that in the principal cell of the cortical collecting duct of the kidney, aldosterone enters that cell and increases expression of ENaC and the sodium potassium ATPase. And that leads to sodium and water retention in the kidney, in the body, which then leads to increased arterial pressure. So, so that's one way. And another way that is aldosterone impacts the central nervous system by increasing the sympathetic tone and causing an impaired baroreflex. And aldosterone also impacts vasculature, causing endothelial dysfunction, vasoconstriction, and vascular remodeling. So all of these are all different ways that aldosterone increases blood pressure. And as I said, this is a huge topic that I don't have time to go into outside of this simple diagram, but we know that aldosterone has deleterious effects on the kidney and cardiovascular health that's actually independent of blood pressure. And this is due to a variety of mechanisms, including inflammation and other things. So now, what happens in primary aldosterone? It also, I wanted to point out that it creates a double hit because you have increased aldosterone impacting the principal cell and causing more sodium retention. Also, you have a decreased renin and angiotensin, which inhibits the sodium reabsorption in the proximal tubule, which then leads to increased distal sodium delivery and therefore more sodium and water retention. So that is kind of our summary of just a background about aldosterone and its biology. And I want to switch now to talking about measuring aldosterone. He's running zebra. How do we catch it? So this was a study that was done a while ago in 1995, where they looked at 5 normal subjects and 10 subjects with known aldosterone producing adenomas. They had these individuals do a 2-gram daily salt restriction, and then they measured aldosterone throughout the day. And they looked at the basal level of aldosterone as well as the bursts of aldosterone and the magnitudes of bursts. This was the plasma aldosterone concentration for a normal individual over a 24-hour period. And you can see that even in individuals without primary hyperaldosterone, it's a highly variable aldosterone concentration. It's a pulsatile hormone with diurnal variation. And adrenal experts say that aldosterone is likely more variable than cortisol. So then what does it look like in an individual individuals with primary hyperaldosterone? They found increased disorderliness and an amplified basal. There were more pulses and they found greater amplitude in these pulses. So again, just a lot more disorderliness with the aldosterone level. So given kind of the pulsatile nature of aldosterone and its variability, how are we going to diagnose primary hyperaldosterone? So the first thing is that really aldosterone needs to be autonomous. So the renin level needs to be suppressed. They call it the sine qua non, meaning the thing that's required to diagnose primary hyperaldosterone. And suppressed renin level is a plasma renin activity of less than 1 nanogram per milliliter per hour. All of the labs that I'm going to go into, that I'm going to talk today, are the standard labs that we use at UW. So you don't have to try to do any conversions, but there are a lot of different ways of, different units. And the Endocrine Society has said that a plasma aldosterone concentration more than 10 nanograms per deciliter or an aldosterone renin ratio more than 20 is diagnostic for primary hyperaldosterone. So that's great. We have these perfect cutoffs for primary hyperaldosterone. We know exactly what that looks like, but it's actually a little more complicated than that. And that's why we need to revisit this in grand rounds. So as an example, Endocrine Society has also said that somebody with a plasma adrenal concentration, aldosterone concentration more than 10 with hypokalemia merits dynamic confirmatory testing. So, you know, there are some cases where they may need more testing beyond these cutoffs. I wanted to include some plasma aldosterone testing pearls as we think about kind of best ways to check this lab. The aldosterone renin ratio is most sensitive 2 hours after waking up. So in hypertension clinic, we usually ask patients to check the level at 8 a.m. The patient should be seated for 5 to 15 minutes before getting that lab test. So often at 8 a.m. lab draw, people are running in to get that lab draw, but they really should be seated, and potassium should be replete. Why? Because aldosterone was evolved to back when we were eating mostly high potassium diets and low sodium diets to really combat hyperkalemia. So a low potassium level can artificially lower the serum aldosterone. And I've really started, and others kind of through my reading encouraged an unrestricted salt diet prior to the testing. A lot of people will come into hypertension clinic, they're very excited to, or, you know, motivated to improve their blood pressure and really understand what's going on. And as a result, they'll be a little more diligent about salt restriction. So, and then non-mineralocorticoid receptor antagonists need not be stopped to interpret the test. And depending on the results of the test, if someone is on spironolactone and they've got a very high aldosterone level and a completely suppressed renin level, there's not many other things that can cause that. And so, you know, spironolactone or other mineralocorticoid receptor antagonists you may be able to interpret the test even with that medication. So that's that's a little bit about the testing, and now I want to really spend the bulk of my talk discussing the biochemical profile of renin-independent aldosterone and some important studies in the last couple of years that have elucidated this profile in renin-independent aldosterone. So to start with, you know, let's look at those individuals who we know have primary hyperaldosterone and what their serum aldosterone levels are. And so this was a study that looked at 51 patients with confirmed primary aldosteronism, and that was based on the Endocrine Society guidelines. And these individuals had to have at least 2 screening renin and renin aldosterone levels. The mean for all the participants was 3 readings, three lab tests, with a range of 2 to 6. They excluded any individuals with a renin value of more than 1 nanogram per milliliter per hour. So, so this is the data for the 51 participants. Each participant is on the x-axis, and the y-axis is the plasma aldosterone level. I've highlighted this 20 here because that's the cutoff for hyperaldosteronism. And the first thing you can see overall is the variability within a given individual. So, you know, some individuals can have very high aldo levels where others can have very low aldo levels. And then you can see also that some individuals actually never met a cutoff of more than 20 nanograms per deciliter for hyperaldosteronism. In fact, 47% of patients had at least 2 aldosterone levels that were less than 20, and 53% of patients had a mean aldosterone less than 20. So the study really highlights the variability of the plasma aldosterone level in patients with even confirmed primary hyperaldosteronism, and also illustrates that the plasma aldosterone concentration may not be the most reliable test. So this study looked at wanted to then approach it from a different level. Since, the plasma aldosterone level may not be quite as reliable, can we try to detect aldosterone in a different way? And they looked at 289 normotensive individuals, 115 individuals with stage 1 hypertension, 203 with stage 2 hypertension, and 408 with resistant hypertension. They didn't, like I said, they didn't use the plasma aldosterone level to define primary aldosteronism, but instead they had every participant complete an oral sodium suppression protocol. And that was just regardless of the plasma aldosterone level, the renin level, and the aldosterone-renin ratio. Of note, they stopped all antihypertensive medications 2 to 12 weeks before the test to rule out any confounders that could be had with blood pressure, with the measurement of aldosterone. So I want to just quickly go over what this dynamic aldosterone testing is. It's an oral salt load for in hypertension clinic, we use 3 days, but the several protocols were used in this study. And so there's 3 to 5 days. On the final day of the salt load, there's a 24-hour urine collection. And the salt load should suppress renin and aldosterone by mechanisms that we discussed before. And a 24-hour urine aldosterone excretion then is checked, and that addresses the potential variability of the plasma aldosterone concentrations. So that's what this oral salt test is. These are the 24-hour urinary excretions for these patients, and it's broken down by the stage of hypertension. So untreated normotension, untreated stage 1, stage 2, and then resistant hypertension. Now, I think we can debate the interpretation of a 24-hour urine aldosterone in patients who are normotensive, and also whether this cutoff of the cutoff is 12 micrograms of urine aldo excretion. That's the cutoff for primary hyperaldosterone. But we don't have a lot of data on 24-hour urine aldosterone levels in normotensive patients or without an elevated plasma aldosterone. So I think that, there's just the interpretation of this and whether or not the urine aldosterone level could, just kind of the interpretation of it, we can talk more about later. But this is dynamic testing. They had a salt load that should theoretically suppress the aldosterone level. But what is illustrated in this data is really a continuum of renin-independent aldosterone levels, and that's paralleled with severity of hypertension. So that was that's why this study is so important. They then calculated those who had the positive dynamic testing, so this cutoff of 12 micrograms of 24-hour urine aldosterone level. So that's in blue. So that's the total population, which they saw, pretty high percentage. And then they looked at those individuals that had suppressed plasma renin level. So that's in orange, or the plasma renin activity of less than 1 nanogram per milliliter per hour. And the prevalence of primary hyperaldosterone was high, and especially quite high in those with resistant hypertension. Importantly, they looked at the sensitivity of aldosterone-renin ratio, and of those individuals with an aldosterone-renin ratio more than 30, they calculated a 26% sensitivity for detecting primary hyperaldosterone in this way. So really kind of interesting data, and this phenomenon was illustrated in the Pathway 2 study, which was the landmark study for resistant hypertension and the use of mineralocorticoid receptor antagonists. So just a reminder, Pathway 2 was a double-blinded, placebo-controlled crossover study that looked at resistant hypertension in individuals with maximally tolerated doses of 3 antihypertensive medications. They did the crossover and 230 participants completed all treatment cycles of spironolactone, doxazocin, bisoprolol, and placebo. An exclusion of the Pathway 2 study was secondary hypertension. So nobody in this study has secondary hypertension. They saw that spironolactone greatly reduced home blood pressure more than bisoprolol, doxazocin, and placebo. And then they also saw that the individuals who had a greater change in home systolic blood pressure when using spironolactone, that there was a greater response to spironolactone with a more suppressed renin. So here's our renin, our change in home blood pressure and renin level, and spironolactone dosing. So is primary hyperaldosterone a zebra or a horse? I'd say it's multidimensional. It's a spectrum, which I think is what we have seen in hypertension clinic. It's not a zebra or a horse, it's a zorse. And this is kind of the new thought on what primary hyperaldosterone is, that it's not a dichotomous yes, no, but that there are individuals with kind of preclinical or early stage mild primary hyperaldosterone who are normotensive. These individuals have low cardiovascular and kidney risks. Then as the disease kind of progresses, individuals can have biochemically overt hyperaldosterone, primary hyperaldosterone, and those that have severe primary hyperaldosterone and higher cardiovascular risk, will have more severe phenotype in terms of resistant hypertension. So to summarize, aldosterone synthesis is regulated by RAS. We talked about how the plasma aldosterone is highly variable and therefore challenging sometimes to interpret that test. And that hyperaldosterone is a spectrum, and that the aldosterone renin ratio can also be not a sensitive test, but and so these binary diagnostic cutoffs may not always apply. And the final point is that the prevalence of primary hyperaldosterone is very high among individuals with resistant hypertension and suppressed renin. So thank you to Matt Rivara and Nisha Bonsall and the Hypertension Clinic staff. And yes, you can ride a Zorse. I want to open it up now to questions. I also have questions for folks too, if yeah. Go ahead. Hi, Ian.
Me. Great talk, Laura, on a very important topic. And that Pathway 2 study is certainly something that's affected my practice. And I use a lot of spironolactone. You said early on the slide of the mechanisms of antihypertensive effect of spironolactone and similar drugs that it could be a whole talk. Can you expand a little bit on that? I've always wondered why spironolactone works well as a drug for refractory hypertension. When added to a diuretic, like in Pathway 2, everybody was already on a diuretic. So maybe it's the natriuretic effects, but it seems like it's likely more than that as well. What are your thoughts?
Right.
Can you?
Yeah, and then we can also talk, Ian, about aldosterone synthase inhibitors too.
Right.
Yeah. So I think I think it's that spironolactone affects not just what's going on in the kidney, but throughout the body, mineralocorticoid receptor antagonism. And so, some of the other mechanisms for aldosterone impacting blood pressure. That was kind of.
But both central mechanisms and vascular mechanisms.
Right. Yeah.
Thanks.
Yeah. Hi, Steve.
Hi, thank you. Well, great. I teach that topic a lot, and I still learn a lot of things from your talk. So thank you. The one question which comes up since you mentioned that there are some in-between results on the aldosterone which may prompt you to do a 24-hour urine. And one question which comes up a lot is, this is an important cause and a more common cause than we think of hypertension. But in a lot of patients, this has been a discussion, for example, on the National ASN site. Maybe we don't need to go that extra level for a 24-hour urine. We just, if they're not interested in surgery, maybe we should just treat them and not trouble them. Sometimes it's hard for the patients, or if they have high blood pressure, to do the salt loading. They don't want to take the test. Why not just treat them if they're not interested in surgery? Have you experienced any differences of opinion on that?
Yeah, so certainly I consider a CT scan and adrenal vein sampling surgical planning. And definitely agree with you that we wouldn't need to do those things if without a diagnosis of primary hyperaldosteronism. The salt load, can be really challenging for patients. And I think, really, it's a great question, because my practice, I think, is changing in this. I like to do the salt load if patients are willing to do it, just so that we really have a sense of whether or not they have the diagnosis. And for the most part, when folks come to hypertension clinic, they want to know, a little more about the cause of their hypertension. And so I usually frame it as, this can help us to, and especially knowing some of the side effects of, the adverse effects of aldosterone. But I think you're right. Not every patient, and certainly, is going to need an adrenalectomy. And so, yeah, I think that's a great question. Thank you.
Thank you.
Oh, I saw Brendan's hand up, and then also Simon. Brendan, did you take your hand down? Go ahead, Simon.
Hey, Laura, great talk. While we're talking about salt loading, any experience using IV over a couple hours rather than 3 to 5 days of oral?
So that is not as sensitive as the oral salt load. So kind of the gold standard for confirmatory testing is the oral salt load. There's also a captopril test, but all those are not as sensitive as the oral salt load. Great question.
Got it. Thanks.
Hi, Fanula.
Hi, Laura. Great talk. Thank you. I had a question, or I just wanted you to comment on the adrenal vein sampling. And the reason, I saw a patient recently in Stone Clinic who was concomitantly seeing an endocrinologist who was evaluating them for primary aldosteronism. And the patient commented to me that she heard from the endocrinologist that there is no one with expertise for adrenal vein sampling at the university. And my understanding is that Valji is one of the leading experts here. And I just wanted you to maybe broadcast that and maybe comment on, what your experience has been with patients that you have referred, and kind of what that process is like. And
yes, that's a wonderful question, because we've seen a lot of patients in hypertension clinic with botched adrenal vein sampling. It's actually pretty traumatic, but not at UW. So Dr. Valji, Karim Valji, is the expert in adrenal vein sampling, and he's very incredibly responsive, and he's never missed it once, and he's also never had any complications in the patients that we've referred to him. So just I trust him implicitly.
Yeah, that's what I had heard as well. And I'll pass that on to endocrinology, and hopefully we can kind of disseminate that information, or encourage them to send these patients to us/you. This particular patient had a systolic blood pressure of 100. So I was doubting the diagnosis. But anyway, thank you.
Yeah.
Great talk.
Laura, question from Liz. about, if you can see it, but doses of spironolactone and how often you're able to peel off other blood pressure medications when you're.
So great question. Yeah. So a dose of spironolactone over 50 is, if you're not seeing a response, then so are you, and I'm assuming that you mean for individuals with primary hyperaldosteronism. So the teaching is that, you know, if you're not seeing a response of spironolactone over 50, then, you know, you shouldn't like kind of keep going up. But I think that's in just resistant hypertension. I've had folks on spironolactone of 20 and or 200, and that's, you know, often kind of guidance with their blood pressure and also correcting hypokalemia. And kind of in terms of removing blood pressure medicines, you know, I still really rely on the first, the three, kind of, you know, the calcium channel blocker, ACE/ARB, and thiazide for people with, you know, resistant hypertension and primary hyperaldosteronism. And I do have a couple of patients who have responded very well to just spironolactone, but they, you know, are like stage 1 or 2 hypertension. Brendan.
Sorry. Have you had, what do you do with a person that has primary hyperaldo and develops renal failures on dialysis and then gets hyperkalemia on spironolactone? Have you?
That's such a good question. And, you know, I think really relates to just in general how well people on dialysis respond to antihypertensive medications as their, you know, kidneys aren't working. Yeah, I think that, you know, as the kidneys fail, it kind of becomes more volume, doesn't it? But, you know, should they be on it? They should definitely be on some MRA antagonism. I think that's a tough one. I guess Lokelma.
Yeah.
That's a great question. Thank you.
Hey, Laura, I have a question.
Hi.
Hi. So have you referred patients for adrenalectomy and had successful reductions in hypertension?
Yes.
Okay.
Definitely. So, and now that Nicole Zern has left UW, there's a endocrine surgeon that we're referring to at the Fred Hutch. And so yes, so I've had folks with resistant hypertension on like 80 milliequivalents of potassium BID who then leave the hospital not on potassium and on amlodipine. And this is actually a really great question, Maggie, because kind of goes into the question of, you know, adrenal nodules and whether or not adrenalectomy and adrenal nodules is, you know, individuals without adrenal nodules. But yes, I've patients that have said, you know, you've cured me, which I feel like I have never had anyone tell me in nephrology before. So good feeling.
Oh, one last question from Bilal.
Oh, hi, thanks. So a quick plug for Dr. Karim Balji. He's great. He's done amazing, you know, results for me. And I've had successful adrenalectomy on at least 2 patients who were cured of hypertension. And then Dr. Balji is not just going to take your word for it. He looks through all the medical records, all the tests that have been done. He brings the patient in for initial consultation, goes over everything with them before he does the test. So he's great. But a quick question for Laura. So you just showed that the sensitivity of the salt loading test or the dynamic salt loading, as you put it, is about 26% in primary hyperaldo. So if you have a high index of suspicion and we get a sort of like a inconclusive negative salt loading test, should we still go ahead and do the intravenous sampling?
Such a good question. I would say, and like I said, my practice is changing more, but I think that, right. So if someone's so basically to summarize your question, if someone's never had an elevated aldorenin level ratio, but then they have this positive, a positive oral salt load, that, how much do you then pursue adrenal vein sampling, et cetera?
So,
That's what you're.
sorry, actually the opposite. So I have a very high initial concern from a screening renal aldo and a ratio that is very suggestive of primary hyperaldo, but then I go toward the confirmatory testing with salt loading, but it gets suppressed. The aldosterone gets suppressed.
Right.
But still the suspicion is pretty high that there is some aldo action going on. So should we just go ahead and still do the adrenal venous sampling?
I would say no on that. But the issue is just, how this is, and just recheck maybe in a year or two. I've had a couple of patients that have had, that have had a negative oral salt load, and then we've been suspicious about primary hyperaldo, and just have them come back and test, and then it was positive the next time. So there's no harm in saying, right now you don't meet the diagnostic criteria for this, but then just rechecking, and patients appreciate that.
Thank you.
Thanks, Laura. Super clinically valuable talk and great discussion. One or two questions from folks in the chat